2:01. I'm going to go ahead and get started. If any of you have questions, feel free to pop them in the chat. I don't have your videos on, and I don't get a little ding when you do send a chat. I don't think there is a way that I can do that. So just know that I will occasionally go in and check on the chat, and I will definitely get back to your question. So if you have a question about something that I comment on, just pop your question in the chat, and then I will be sure to get to it. So I'm going to just dive in here. I'm hoping this is going to take about 30 minutes. If you guys have more questions, I am happy to stay longer. So talking about weight loss, this is a charged topic because it is so complicated. There are so many different factors to consider when it comes to weight. So a little bit just starting here on weight and understanding what's happening. Obesity is super complicated. There are so many things really learned over the years that affect people's metabolism. Not only is it biology and food and our genetics and life events that happening, but it's also very much about how we interpret our connection with the environment, our environmental toxins. And now I think even social media has had a huge effect on it. And this concept of even marketing affecting our health and our weight, it's huge. We're very impressionable creatures. And it's very easy for an advertisement on Facebook to seduce us into thinking such and such. And, what we've learned over the years, when I first started practicing medicine, fats were bad. And everyone was avoiding fats. But then all of the salad dressings, in order to get them to taste good, were full of sugars. And so it's been interesting to watch over the years how all of this has shifted. So when it comes to how do we assess for obesity and how do we decide if the person is labeled as being overweight, there's a number of different ways of doing it. As children and teens, doctors need to take into account activity level and growth level. There's caliper testing, which is measuring fat. There are ultrasounds that will measure for body fat. There's, you can do waist circumference measurements, and that can put you into kind of a good or an unhealthy weight measurement. There's also a height to weight ratio a height to waist circumference ratio that you can use. And then we have a number of lab tests that assess physiology and assess health. And I think the bigger picture is more important than just one of these markers. Many of you have probably heard of BMI, body mass index. Body mass index is kind of the most commonly accepted way of measuring if somebody is in a normal weight or if they're overweight. So body mass index has to do with your height and your weight. And if you just Google BMI calculator, you can plug in your height and your weight, and it'll tell you what your BMI is. A normal BMI is basically between 18.5 and 24.9. And then here you can see are the different categories. The problem with obesity is that obesity also increases your risk of so many other diseases. It increases risk of cancers, mood disorders. It increases your risk of cardiovascular disease, heart attack, stroke, reproductive problems. So helping people to, achieve a healthy weight and maintain a healthy weight, it's not just because people want to feel good in their bodies. It's also because we're wanting to lower risk of other chronic disease. When it comes to weight loss, I try to help people understand that there's a number of root causes. So on the top here, these are the diseases associated with obesity. And on the bottom, there's a number of root causes. I have another slide that goes through even additional root causes. When someone comes to me and their primary concern is they need help with losing weight, we have to look at all the root causes and figure out which of the root causes are their biggest obstacles to achieving that goal. So there's immune problems, structural problems, inflammatory problems, hormonal, chemical, digestive, and mitochondrial. I'll talk quite a bit more about mitochondrial at the end. These are my root causes. So the first thing I always make sure we've done is we've properly assessed for thyroid dysfunction. Hopefully your physician has already helped you with doing that, but that would be thyroid labs like TSH, free T3, free T4, and sometimes I'll also do reverse T3 or thyroid antibodies. The thyroid is the master gland of metabolism. It sits right here on the neck. And if that's not functioning optimally, then it doesn't matter what else you do with everything else. You'll be spinning your wheels. So I'm sure somewhere on our website, we have the optimal thyroid goal range, but your TSH should really be less than, I say 2. It should be less than 2. So go back to your last TSH lab when your doctor checked your thyroid. And if it's above a 2 and you have a number of the hypothyroid symptoms, that might be proof enough that at least you have some sluggish thyroid function. You might not be overtly hypothyroid and need thyroid medication, but you definitely might still be sluggish thyroid, and that could potentially help you with achieving a more optimal weight. The adrenals are the glands that help you manage stress. So labs to assess for adrenal function would be cortisol, and you can either do cortisol just as a morning cortisol, or you can also do a salivary cortisol multiple times throughout the day. History of steroid use can affect your ability to maintain your proper weight. Low testosterone. As women age and as we get into and go into menopause, perimenopause, and postmenopause, our testosterone levels decline. Testosterone helps maintain muscle mass. Muscle is more metabolically active than fat cells. So the more muscle mass you have, you actually are burning more calories just when you're sitting. So as a woman ages and her muscle mass starts to go down, I'm always checking to make sure, A, she's getting enough protein to maintain that muscle mass, and B, her testosterone is still sufficient. So check your testosterone levels, and don't rely on the normal reference range for testosterone. I want a woman in the middle of that reference range, not at the low end of the reference range. Not having enough dietary protein. This is huge. You're going to hear this as a theme of today's talk, but protein is key, not only for maintaining and optimizing your weight, but also when you are on the GLP-1 medications, maintaining adequate protein is key so that you don't lose muscle mass. Insulin resistance or prediabetes. So those labs are hemoglobin A1C and insulin. Those are the primary labs that I will use to assess for blood sugar function. And that will tell me a lot about their diet, and it'll also tell me how good their blood sugar metabolism is. Sleep. If a person is not getting enough sleep, then all the other weight loss efforts, they will be spinning their wheels. So on multiple cases, I have just assessed a person and realized, I don't think you're getting enough sleep. I think you need more than your 6 hours, or I think you need more than your 7 hours. Personally, I need 9. I am a 9-hour a night. Before the light bulb was invented, on average, humans slept 9 hours a night. And I am definitely a pre-Edison light bulb sleep person. If I don't get my 9 hours, things definitely go wrong. Toxic burden. We are inundated by toxins in the environment. And there are tests for this. I tend to not go down the rabbit hole of testing, and instead I will just put people on monthly detoxes for a while. And there's a variety of different detoxes you can do. Estrogen dominance, or the same way of saying it is progesterone deficiency. There's a number of reasons that our estrogen progesterone ratio gets off. That's another talk, but that also can affect your metabolism. Having a low metabolic rate, food sensitivities, gut dysbioses. Another common one we'll talk about later is SIBO, which is a bacterial overgrowth in the gut. Nutrient deficiencies and mood disorders. All of these can affect your ability to get to your optimal weight. So diving right into the peptides here, I'd love to know how many of you are familiar with peptides, and I realize that you might not all be as familiar with peptides. So I'm giving you a little bit of an overview here on what peptides are. So the world of peptides has exploded in the last 3 years because of these GLP-1 medications, but these medications are not new. Many of these medications have been around for 10, 20 years. A peptide is a string of proteins, it's a string of amino acids before it gets folded into a protein. So amino acids are what proteins get broken down to when we eat them. And just to give you a bigger picture here, we've got our fats that we eat, our fibers that we eat, our carbohydrates that we eat, and our proteins that we eat. Our proteins are really a whole bunch of amino acids. There's about 30 different amino acids. Some of them are called essential amino acids, and some of them are non-essential, which means our body has the ability to make them from other amino acids. So a string of amino acids is what a peptide is. That's pretty much it. Peptides are naturally occurring in the body. The first commercially available peptide was actually insulin. And we know diabetics inject insulin with a little insulin syringe. We've all seen these syringes. We've seen Sharps containers at the airport for syringes, and we knew that these were for insulin, which are for diabetics. Peptides are molecules that are usually between 2 and 50 amino acids. Once there's more than 50 amino acids, it's pretty much no longer a small peptide. Now we would really call it a protein. Our body uses these peptides as signaling molecules to stimulate various chemical pathways in our bodies. And there's a number of different peptides that all have different jobs. So they're basically tiny little protein messengers that tell our cells what to do. Now, the world of peptide therapy has exploded. We've got growth hormone peptides. We've got repair and recovery peptides. There's some sexual peptides, sleep peptides, anti-inflammatory peptides, and there's some peptides that enable weight loss. Peptides can be used for autoimmune conditions, MS, cancer. Anti-aging is huge. That's really where you're probably hearing more about these peptides. Mood enhancement peptides, weight loss. Most peptides can be given in these three ways: injectable, oral, and transdermal. Most of the peptides I use are injectable. I've experimented with some of the transdermals and some of the capsules. They don't work as well as the injectable. So diving into the GLP-1 medications. So semaglutide is a GLP-1 medication. Tirzepatide is a GLP-1 medication, and it's also a glucagon inhibiting peptide. So this has a dual action. Retatrutide is another peptide that actually has a third action. So all of these peptides are starting to come out and become a bigger, we're hearing about them in the news. So the big one you've probably all heard of is Ozempic. Ozempic is the same thing as semaglutide. Wegovy is the same thing as semaglutide. Mounjaro, which you've probably heard of, this is the same thing as tirzepatide. And you can either get these as a brand name. Now, the brand name medications come in a pre-filled pen that you can adjust, and then it dispenses the pen with the needle, and you stick the needle into your belly. You can also get some of these medications compounded through compounding pharmacies. So the GIP, the way that they work is that they're basically helping our pancreas work more efficiently at processing sugar. And they also affect how our appetite is in our brain. This is another picture that's kind of explaining. So we've got the GLP-1, which is semaglutide. It lowers glucagon. It's going to help with enzyme secretion from the pancreas. We're going to make more insulin, which actually is going to lower our blood sugar. So semaglutide is a GLP-1 agonist. It stimulates insulin secretion. It inhibits glucagon secretion, thereby decreasing blood sugar. Now, one of the primary causes of weight gain and difficulty losing weight is that there's too much sugar around. Now, I've done a lot of weight loss treatment over the years, and I can tell people, and for years I had a weight loss protocol was no sugar, no dairy, no grain, and limit your calories to 1,200 calories a day. And that worked to help people with losing weight very, very significantly, but it didn't help everyone. And as I've progressed over the years, one of the things I've realized is menopausal weight gain is one of the hardest things I treat. Helping women that have now gotten into menopause and their hormones have shifted, it is really hard to help them lose weight. So I branched into using the GLP-1 medications about 2.5 years ago. And to me, it is just another tool in the toolbox. Sometimes it's not the right choice, and sometimes it can really help turn things around for women, especially when they've already done everything else on my list. Now, another way the GLP-1 medications help with weight loss is that it slows gastric emptying. Now, what that means is it takes longer for food to leave the stomach, which does two things. It helps you feel full much more quickly. In other words, you eat a third of what's on your plate. And the other thing it does is it is the cause for most of the side effects. So we'll go through what a lot of the side effects are, but a lot of the side effects are happening because of this slowed gastric emptying. So the benefits of, I'm just going to focus on semaglutide right now. It's not just helping with the insulin and the blood sugar. It also, it has a number of other effects too. It's anti-inflammatory. It actually there's some research that shows that it has been good for mood disorders. It helps with protein synthesis. It lowers cholesterol, which is this triglyceride and LDL. Because it lowers blood sugar, you're lowering hemoglobin A1C. I have a number of diabetic patients that I have reversed them out of diabetes. Well, one question is can I keep them out of diabetes without the medication, or are they going to need the medication for life? And that's a very good question, which we'll talk about when we get to some of the side effects. Because we're lowering blood sugar, you also see a reduction in blood pressure. Because they're losing weight, you also see a reduction in that blood pressure. It definitely handles appetites and cravings. People's appetite definitely goes down. Now, in some ways, you need to be careful that it doesn't go down too much, because we need to make sure that they maintain adequate protein intake to help maintain muscle mass. But for people that have a hard time controlling their diet because of cravings, now, number one, if they really do have a problem with cravings, I'm also now thinking they probably have a neurotransmitter problem because of stress. When our body is stressed too much, too long, for too long of a period of time, our body will use up its stores of its anti-anxiety neurotransmitters. Glycine is one of our anti-anxiety neurotransmitters. And if we're stressed for an extended period of time, we use up our savings account of glycine. And then when an anxious situation happens, we don't have any glycine in our savings account and we are anxious. So that can then lap over into another neurotransmitter, serotonin. And if the person is having craving problems, they probably have an imbalance in their neurotransmitter like serotonin, and we can support that with other supportive agents like 5-HTP, 5-alpha-tryptophan, 5-hydroxytryptophan. That's another nutrient that helps the brain make serotonin. Dysbiosis, semaglutide actually can help with this because it is helping with the gut function, because there's not as much food coming in. And because there's not as much carbohydrate coming in, then the balance of the macronutrients in our diet is shifting. And then the bugs are eating a different ratio of food, which actually is better. Most people eat too many carbohydrates or too many sugars. And then, of course, semaglutide is also going to help with our insulin. That's how it's helping with all of these things. So those are the benefits. This is an example. So semaglutide and all of the GLP-1 medications are dosed one time per week. That's it. It's just an injection one time per week. Now, this is just an example. 5 units at bedtime for weeks 1, weeks 2, week 3, and week 4. And then at month 2, you can increase the dose. Now, depending on how the person is tolerating it, I will very, very customize the dosage so that they're not having side effects. I actually now even start people lower than the 5 units. And for many patients, I just microdose it. They just sometimes need a microdose to get the control over their cravings, their appetite gets better, and they notice already that their metabolism is a little bit better. So I don't want to overdose these people. And I will say the majority of the side effects that I have seen have been dose dependent. So this is an example of a semaglutide protocol. Tirzepatide is what I use if the person does not tolerate semaglutide or if they're not losing weight on semaglutide. So semaglutide is kind of my phase 1. If they're not tolerating it or they're not losing weight, then we switch to tirzepatide. Tirzepatide has all the same actions as semaglutide because it's also a GLP-1 medication, but it's also a GIP, which means you have some extra functions. It's basically got 2 different mechanisms that help with the same thing. And what this allows me to do is to keep the dosage a little lower because you've got 2 mechanisms of action and they're able to tolerate it better. So if people don't tolerate the semaglutide very well and they're not losing weight, I'll sometimes switch them to tirzepatide. This is an example of a tirzepatide protocol. Now it's the same thing where it's an injection 1 time per week. So every Wednesday night, and that's it. And this is an example of how I usually start them at 10 units, and we do 10 for a couple of weeks. If they're tolerating it beautifully, then we go up to maybe 20. And then in month 2, we go up to 20 or 30 and then up to 50. And you actually can keep going up on this one. This one goes quite higher than that. Now, the side effects of these medications are primarily related to the delayed stomach emptying, that delayed gastric emptying. I'm just going to check the chat and see. If anyone has any questions, feel free to pop the questions into the chat, and I'll go back there and make sure that I've answered those. So these side effects, as I said, are related to the delayed gastric emptying, and it makes sense. Imagine food doesn't ever leave your stomach. You're going to feel full. You're going to have nausea. Some people do throw up, and this really sucks. And this is why I have erred on start with a much lower dose than you think, and you can always wean up. So nausea, vomiting, some people get constipation or diarrhea, acid reflux can happen. And then of course, the side effect that everyone's talking about because of what they see in the news is the muscle loss. Now, I don't see this very often because of 2 things. Number 1, I am microdosing people, and I start with a much lower dose, and I go slow and steady. And the other reason I don't see this as much with my patients is because I am adamant about them getting enough protein in. And if they're not doing enough food, which many of them are not because their appetite is less, then I'm going to make sure that they're doing some sort of a protein powder that's going to have enough of the adequate amino acids that help with maintaining muscle mass. Other potential side effects. Now, these are the scary potential side effects. As of now, and I've helped about 150 people through GLP-1 or a semaglutide or a GLP-1 protocol. As of now, I have not had any of these problems happen, knock on wood. I also note, and I've discussed this with my colleagues, is that these side effects are already potential complications of diabetes. So these are potential side effects that are reported, and these are the side effects that are scaring people away from using these medications. But I always like people to just notice gastroparesis. This is a paralysis of the digestive system where food doesn't move through at all. Obviously, that's a problem. Now, that's a common side effect in diabetes. So when they report these potential side effects happening in people using these medications, I don't think it's the medications that are causing these side effects to flare up. I think it's that the people in the studies that have been given these medications, all of whom are already diabetic, are already at risk for these complications. Now, whether the medication tipped them over the edge and caused these side effects to happen, or if it was just a correlative thing that they're seeing in the research, I don't know. So I am watching for these side effects, and I am microdosing people to minimize the likelihood of these side effects. I've had no gastroparesis problems. I have had constipation problems, but we treat that and make sure that our treatment is efficiently preventing that from getting worse. I haven't had any kidney problems, gallbladder problems, or pancreatitis problems. Now, thyroid cancer, this is really more of a correlative problem, not a causative problem. If you look in the research, I still would be cautious giving semaglutide to someone that has a history of thyroid cancer, particularly what's called the follicular type of thyroid cancer. I would be careful of that. It has not caused thyroid cancer in humans to date. It looked like it triggered thyroid cancer in rats. So I would be cautious in that situation. Now, there are some reasons to not use these. If the person already has a kidney disease, if they already have a lymphatic or a thyroid cancer, or if they already struggle with hypoglycemia, then I would probably avoid using these. Now, just a few pearls for success. Now that I've been doing this for a while, I've really learned how to be more successful at it. Side effects, managing the side effects are huge, because if the person is having side effects bad enough, then they can't increase the dosage of the medication to a point that's therapeutic, or they're not going to lose weight. So if they're having nausea or vomiting, then we have to prioritize protein. I do sometimes recommend ginger. I have some essential oils. I have some homeopathics I use. Sometimes I will prescribe Zofran, which is an anti-nausea medication. It's a really safe anti-nausea med. It's used in pregnancy. Now, if that doesn't work and the nausea is still severe, then our only options are to microdose or to try tirzepatide and see if they tolerate that better. But 95% of the time, I can get it to where that they're tolerating it okay. Now, constipation is obviously not fun. It's not good. It's going to cause other problems. Magnesium is usually what I'll do to get things going. Now, there's multiple forms of magnesium, and the form that I would use is usually a combination of magnesium oxide with maybe a little magnesium citrate. So if you are on this, if you're on a GLP-1 medication and you're having problems with that, make sure you talk to your doctor about the form of magnesium, because in order for the magnesium to help, it has to be the right form. And then the other side effect is this loss of muscle. And this is really key for maintaining muscle mass, is they have to have enough protein. And resistance training. They have to have resistance training. Now, one of the things that I also talk to people about is when they get off these medications, or actually, let me back up. How long do they need to be on these medications? Everyone is very different. I have had patients lose, I've had patients where it's taken them 6 months to lose 15 pounds, and I have had a woman lose 60 pounds in 9 months. So there's a huge variation in how quickly people can lose the weight depending on how well they're tolerating it. A question is once I get to my goal weight, can I just stop it? And I've kind of have two schools of thought here. Some of my patients where it took them a really long time to lose the weight, and they struggled with appetite problems and craving problems, and they had a hard time eating properly before. I explained to them that the longer we can get your macronutrients in line with the way they need to be, and the longer they have been doing strength training to increase their muscle mass, the more likely that they're going to be able to get off of this very quickly and maintain their weight. Now, maintaining their weight really comes down to two things: protein and strength training. If they're not doing protein and strength training, most of the time I see people gain the weight back. Now, gaining 5 to 10 pounds back after a 30-pound loss is pretty common, and it's almost to be expected. So I kind of warn people that that's going to happen. So I also have some people that have told me that they feel so much better taking it that they don't want to stop it. And I have mixed feelings about that. But for the most part, if we're microdosing them, and I'll spread out their injections, so they're doing an injection once every 2 or 3 or 4 weeks, that's minimally an invasive thing that's still also helping them. And at this point, I've really considered this a valuable tool in my toolbox. Now, it's not the only tool I use for weight loss. And if they only use this and they don't use all the other tools, they inevitably will gain the weight back. And I make sure that's clear at the beginning. So we talked about the side effects, and I really explained, I really think these are dosage dependent. So most of the side effects I'm not as afraid of as the media is making it. Now, I've also had a number of patients where I've discovered that they have a sensitivity to it. They have the nausea. They don't feel good on it. And it's usually because they have some sort of an underlying gut issue. So for these patients, we need to treat the gut before we dig into those GLP-1 medications. So do they have leaky gut? Do they have irritable bowel syndrome, or do they have small intestinal bacterial overgrowth? Now, in my experience, this is all the same thing. All three of these are the same. When I'm treating IBS, I know it's usually an underlying SIBO thing. This is also an interesting slide. This is showing that our body, we actually make GLP-1 in our intestinal cells in our body. And so making sure we have a healthy gut lining, if there is any evidence of gut symptoms, I'll add butyrate, butyric acid, which is a short chain fatty acid that's right here, short chain fatty acids. These are the guys that help to fuel and heal up these intestinal cells. So we make GLP-1 in our own gut. And there's a number of things that help our body with making it itself. And one of those things is butyrate. So I will also give a person butyrate during or especially after their GLP-1 protocol to help them with continuing to make their own GLP-1. Protein. Now, we mentioned how important protein is. I will aim for people getting 0.9 to 1.3 grams of protein per kilogram of body weight. So, and I should have written this out for you, but what I do is you take your body weight. So I'm 155 pounds, divide that by 2.2, and that will give you how many kilograms I weigh. So I think that's about 68 kilograms when I do 155 divided by 2.2 is 68 kilograms. So if I weigh 68 kilograms, I multiply that times a 1.3. Now, the reason for the 0.9 to the 1.3 is it depends on how physically active the person is. If the person is pretty physically active and they're working out a couple of times a week, I usually multiply it times a 1.1, 1.2. If they're really physically active, I'll multiply it times a 1.3. If they're pregnant, I will multiply it times a 1.5. Because they're making another human being and they need extra nutrients to make that little baby. So if I weigh 68 kilograms, I don't think you can see my calculator here, but 68 times a 1.2, that means I need 81.6 grams of protein per day. So let's say 80 grams. So making sure that you're getting enough protein. Now, some nutritionists will even err higher than that. I've heard of many patients coming in and they're having 90, 100, 110, 130 grams of protein per day. I'm okay with that for short term, especially when they're in the weight loss phase, then they do need that much extra protein. Now, leucine is an interesting amino acid. This specifically helps with maintaining muscle mass. I have another slide on that. And the branched chain amino acids, which leucine is one of the branched chain amino acids, helps with maintaining muscle mass. And then collagen. This is a collagen that I use to help with bone support, osteoporosis, hair, skin, nails, and then it also helps with maintaining bone. So leucine plays a critical role in preserving muscle tissue. It activates the mTOR pathway, which is essential for muscle protein synthesis, which helps to maintain muscle mass during weight loss. So this is a protocol that I have added. Now, I don't add all of this with my GLP-1 protocols, but I definitely have this in my brain as a potential of when I need to add it. So during the GLP-1 medications, we need them to be on some sort of a branched chain amino acid powder that particularly has enough leucine in it. There's also nutrients that I use for just supporting healthy metabolism: glycine, taurine, carnitine, and those are all in kind of a metabolic multi that I use. Pancreatic enzymes. Now, this is particularly if they have any digestive issues or if going into it, they didn't have healthy gut function. We want to help and support this because that will minimize the likelihood of them having gastric problems on the GLP-1s. A probiotic. If they're nauseous, another thing I've used is vitamin B6. This is P5P or pyridoxine 5-phosphate. This is the activated form of vitamin B6. A charcoal. Sometimes I will give a charcoal. This is a binder, which helps to bind up toxins. So if the person is having headaches on the GLP-1s, there's potentially a detox reaction happening. And so I will give charcoal, and charcoal is a binder that will bind those up. If there's a thyroid problem, I'm making sure there's thyroid support in there. If they're having diarrhea, that's sometimes a deficiency in this probiotic, Saccharomyces. If they're having constipation, I'm doing magnesium. And if they're having acid reflux, I'm usually giving DGL. So this is kind of my protocol for during. And then after it's also really important to optimize those macronutrients. So again, your macronutrients are protein, fat, fiber, and carbs. And making sure that you're on the right ratio of all of those foods is going to help with being successful at keeping the weight off afterwards. That branched chain amino acid or leucine is important. Now, you've probably heard of BCAAs. You know, these are oftentimes advertised for muscle builders as a protein powder because, again, it helps with muscle building. And then the metabolic multi, I still use. Blood sugar support, I'll usually add in, especially if they had insulin resistance prior to being on the GLP-1 medication. And then there's also tricks you can add in that help with satiety. This is, fiber and fat in your diet is going to make you feel fuller quicker. So when they stop the GLP-1 medications, it's important that their macronutrients are balanced, but I'll tell them to eat your protein and your fat first and save the carbohydrate for later, because you'll find that you'll actually be fuller sooner than you expected if you had the protein and the fat first. The butyric acid, I mentioned that slide where we make our own natural GLP-1 medication in our intestinal cells. And so this butyric acid is fuel for those intestinal cells to do so. Inositol, this is a nice nutrient that helps insulin metabolism. And so sometimes I'll throw that in the mix, particularly if I have PCOS patients trying to lose weight. And then, of course, the collagen we talked about. So these are the nutrients that I'm using kind of during and after my GLP-1 protocols. Now, some people will go through around, they'll be on a GLP-1 for 4 or 6 or 9 months, and they'll lose a bunch of weight. And I'll have them take a break. And then if they didn't lose all the weight they wanted to lose, let's say they had, 60 pounds to lose and they only lost 35 pounds. After that 9 months, I usually have them take a break for maybe 4 to 6 weeks, and then we'll go back on it and we'll do another round. And I do have people now needing to do multiple rounds. So hopefully that gives you guys a little bit of an overview into the GLP-1s. I'm going to check in and see if you guys have any questions. So far, no questions. I did have a couple of other slides on some of the other peptides that I was using, but we are already at 2:40. And I think I might save those for another time and let you guys just absorb the GLP-1 information. I'm just going to see one more time if there's any more questions. Well, everyone stuck around for the whole talk. So I hope this was informative and educational. I'm going to check one more time. I think that you guys are good on questions. I know there's also a delay, so I'm going to give it one more sec. The only other slide I think I might give you guys really quick is I want to tell you guys about methylene blue. This has become, I have to skip these slides. They're being very finicky. Slick, stick, 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 stick. Methylene blue has become one of my favorite support. Here we go. So for those of you that want to stick around and learn about methylene blue, I'll give you guys a quick overview of methylene blue. Oops. Sorry, these slides are very delayed. Okay, so methylene blue is a dye. You probably remember this. Methylene blue is the dye. It's been used for microbiology over the years to dye slides on a slide. They've actually used it to dye blue jeans. But we've discovered that methylene blue is transformative for supporting the mitochondria. The mitochondria are the little energy-producing organelles inside of the cell. So inside of the lining of inside of the cellular wall of the cell, at low doses, methylene blue is called an electron cycler. And so what it's doing is it's helping your electron transport chain make ATP. ATP is our energy molecule. Methylene blue is FDA approved for methylhemoglobinemia and cyanide poisoning, but that's when it's used in high amounts. In lower levels, it's actually supportive for the mitochondria. So I don't know if you've seen people where they have a blue mouth, but when you suck on a methylene blue lozenge, it dyes anything it touches. I did the lozenges for a while, and it absolutely dyes your tongue. And not only that, it turns your pee blue, which my son absolutely loved. It was hilarious. He called me a Smurf because the pee was literally blue. So you can take this either as a lozenge or as a capsule. It helps with making ATP. It helps with memory and cognition. It increases oxygen production in the brain. Excuse me, not oxygen production, oxygen utilization in the brain. So it's actually making your brain cells more metabolically active. It increases NAD, which again is another one of our energy molecules. It increases a neurotransmitter called cholinesterase, it functions as a cholinesterase inhibitor, which then increases the amount of acetylcholine we have. And acetylcholine is a neurotransmitter in the brain that helps with arousal and attention and memory and motivation. So methylene blue is a little bit like it's like a waker-upper, but not a stimulant like caffeine. It's used for mitochondria support, as we mentioned. It's an antioxidant. It helps with, as I'd said, oxygen utilization. So I have people using this if they are training for some sort of a marathon or if they're training for a hike at high altitudes. And then it also can function as a monoamine oxidase inhibitor, which is the enzyme that our body uses to break down dopamine. So if you inhibit that enzyme, then it actually will increase those neurotransmitters. So it also is a mood enhancer. Now, I'm using this for some weight loss, but I'm also using this for mitochondrial support. Biofilms. This is a concept I go over in my SIBO talks, but biofilms are kind of this film that the bacteria in your gut put around themselves. And sometimes it can be very difficult to penetrate the biofilm if you're trying to kill off SIBO. And methylene blue, because it's an antibacterial, antiviral, antiparasitic, it also can help with killing off that bad bacteria. So if you're interested in methylene blue, this is another thing that you could potentially talk to your doctor about. It is a prescription. It comes in lozenges or capsules, depending on the size, the dosage. But in my research in the last, year and a half of peptides, methylene blue has popped up multiple times. And I've now been using this for the last maybe 6 to 8 months or so. And I don't have people be on it long term. I just have people be on this short term. So I have them do maybe 3 to 4 months on and then 1 to 2 months off. And then we go back on it. It's kind of an on and off thing. Let me see if anyone has questions. Awesome. Well, I hope the little extra methylene blue info was interesting for you guys. And if you guys have any other questions that I didn't get to, feel free to email the office. I hope that you guys have a lovely Friday afternoon and enjoy the weather. And hopefully we don't have any more downed trees this weekend. So you guys have a great afternoon.